Good evening. We'll start the second session, part 2 of our class on professionalism and ethics. We covered the basic tenets of ethics, and I think it's good to have a little recap. Samir, tell us the pillars of ethics that we talked about last time.
Hello?
Yeah,
Yes,
tell
sir.
us, please. Just mention them.
Beneficence, non-beneficence, and justice.
Only 3?
4, sir. Autonomy, beneficence,
Autonomy.
non-beneficence, and justice.
There's one more, we mentioned another important one. Confidentiality. Okay?
Okay.
Yeah, confidentiality. That's another one. Ines, we also talked about some values. Okay, what are those? That do you remember the basic? Just mention a few.
Compassion, sir.
Compassion, very good.
Then so like their skills, utilizing like the proper skills.
All right, updating of skills. Yeah.
And like following rules and regulations to implement those skills.
All right.
And sorry, these are what I can think of.
Integrity.
Yes.
Above all, honesty, integrity, compassion. These are some of the values that we should follow. And so it is said that you don't talk about ethics or give a didactic lecture. Most of ethics is learned by imbibition. Right? What does imbibition mean? Praveen, you imbibe something.
Absorption from the surroundings, sir.
Yes, absorption from the surroundings. You just watch what happens around you and absorb. Okay, and so what it basically means is that all of us, in our own capacities as teachers, students, staff, everything, we must live ethics. We must work and live with ethical outlook, and everybody else around us will absorb it, and we will absorb it from everybody else. What is very important is that in real life, you will see that there's a lot of unethical things being done. And so you have to have the discretion. You're all adults, so you must have the discretion to know what is right and what is wrong. If you remember the slide, my slides on professionalism, one of them was a very, very clear thing. A professionalism, one of the tenets of professionalism is to be able to differentiate between right and wrong. And so you need to understand that. So what I'm going to do is show you some of the cases that I have myself, and I'm sure all of us will have faced all these things. Yeah, go on. Ravi.
And there is a very beautiful Kannada thing. Kelavam Ballavarinda Kaltum, Kelavam Sugnanadim Kelitam, Kelavam Malpavarinda Nodutam. So
absolutely.
I think ethics is something that you know the basic tenets that you learn, and then you see how it is being put into practice or not put into practice, and then use your discretion to learn right from the wrong. But other thing is, the only important thing is that today there was the orthopedic surgeon was saying that a patient went to him for a surgery, and the indication that he gave was correct, and he advised him to undergo the surgery, but he saw somebody else, and that fellow said you don't need surgery. So the patient wrote a very bad blog saying that this man is unethical. So this man has gone on public and said that he is one of the most ethical persons he knows, and all these things, and he criticized the other surgeon and everything. So ethics is also about not speaking ill about others, even though your opinion may be right, but it is important to not criticize others for what they have done, because your yardstick and their yardstick may not be the same.
Very true. Very true. Okay, so we'll have 4 or 5 case scenarios, and I'm not looking at the surgical aspects of it, but only the ethical aspects of it. What would be the conflicts that you think of in these situations, and how would you resolve it? Conflict resolution comes a little later, but basically we need to know what the conflicts are. So here you're a casualty officer, you have a lot of cases landing on your lap, you're alone, and you really don't have the bandwidth to treat all of them. And you can't get help. You would obviously send them away somewhere. You can't send them somewhere. Perhaps, what would you do? Nikita?
Sir, choosing the patient whom to first resuscitate would be the problem, sir, and
Yeah.
resources management would be the issue.
So what is that process called?
Triage,
Yeah. So what would be the ethical conflicts in a triage?
The black versus the green, sir. Like
Yes. So what are the
age related.
we mentioned 5 pillars. What are the conflicts? What are the pillars that are bringing you into conflict?
So beneficence versus justice, sir.
Correct. All right. So justice is you want to do the most good to most people, but if you look at that individual person whom you are saying, I don't think I can resuscitate this person, you are not benefiting him by putting him in black or whatever, one of the higher grades of ethics. So this kind of conflict occurs between various tenets, various pillars of ethics, and that is the idea of these case histories. Here is a patient with multiple injuries, cannot afford. You are in practice. There is nothing that you can do because patient can't afford it, and you can't send her away because she doesn't have the time. What would be the conflicts in this? One of them is beneficence. You can't benefit the patient because you can't treat.
Non-beneficence, no.
But you can't treat. So you're beating non-malfeasance. Okay? You do no harm, but because you can't treat, indirectly you're harming the patient. You understand? So this is the conflict. But what does the law say about this? Please remember that ethics is always above law. Law is a basic minimum. Ethics goes one level higher, which is, that's what we call morality, moral obligation versus legal obligation. So I just want you to know, what is the legal obligation in our country in a situation like this? Praveen?
Don't refuse to treat, sir.
So what are the things that you're expected to do legally?
At least give a first aid and
What is first aid in your
sir.
definition?
Sir, make his vital stable, sir.
Okay. How do you do it? You guys talk in all generalities. You can't admit the patient. Patient is very ill, multiple injuries. So what are the minimum things that you need to do?
Sir, we'll do the ABCD, sir.
Okay. So what are the things that you maintain as an... See, I want you to... It's a very practical question here. You keep beating around the bush. The kind of answer... Okay, Nikita, have a go at it. What is it that you would do as a casualty officer?
Sir, we'll intubate the patient, and depending
Yes.
upon all the fractures, we'll put the splints and start
Yes.
resuscitation.
Excellent.
Then
And put a drip up. Those are the only three things that the law expects of you. Airway maintenance, intubate the patient if required. Patient is in pain, give painkillers, put a couple of drips, start a drip, unstable fractures, put splints, pneumothorax, put a chest tube, and do all these things and then send the patient. And don't charge. They can't pay, the patient can't afford anyway. But this is what you need. That is the law. But is it ethically correct? It isn't. So as doctors, we must go one step higher and see if you can talk to your seniors, even in a private hospital, and say, look, can we find some way of helping this patient further? Okay. And if the administration accepts, then you can continue to look after the patient. Otherwise, you're covered within your legal rights to send the patient away. But these things can happen, and this is what you need to know when you're in a casualty department in a private hospital. 89-year-old comes with breathlessness, vomiting, pain abdomen. Initially coming under the physicians, because all these have happened to me. That's why I'm explaining this. None of this is fiction. Admitted under a physician, thought of aspiration, possible MI, ruled out, discovered to be septic, all right, with an altered LFT, and ultrasound done because of some vague abdominal pain, no guarding or rigidity, shows acute cholecystitis, features stones, thickened gallbladder wall, and pericholecystic fluid. What do you do?
Again, we'll admit the patient.
All right.
The,
Ethical issues. What this in decision
Sir,
making?
if the patient previously before this episode, if he's all right and like mobile,
Excellent.
his general condition.
That's all I wanted to hear from you. The first thing you do is talk to the family. What was his condition before he got ill? That's the first thing, because all the decisions that you take afterwards will depend on that. This guy was compos mentis. He was active. He was actually taking walks outside the house. Not a lot, but a little bit, but very much with it and active. So what happens next?
If he's active person, we can actually plan for a management, surgical management, depending upon if required ERCP or not, sir, CBD exploration and all.
All right, good.
Not, we can go for a palliative or if like downgrade and just for the.
Why do you even think of palliation here? Because the patient is very active. What would make you think of palliation?
If the patient doesn't want aggressive management.
All right.
If his will is different, sir. Like,
very good. Advanced directive. That's the next thing. So after looking at his activity, the next thing is his advanced directive. What does he want? Does he not want any surgery at any cost? Or he doesn't mind that? But does he not want ICU? He wants ICU. If he goes into, if he gets worse after surgery, you have to put him into ICU. Do you want the ICU care? You don't want the ICU care? No, exactly this kind of conversation happened between me and the family of the patient. So they want, they said he was fine, and they clearly said that if he gets worse after surgery, we don't want him on a ventilator. But short of that, you can do what you want. So this patient actually had an MRI which showed stones, had an ERCP, cleared the stones, and then I did a lap poly, and the patient got better. Okay. And as expected, his recovery has not been great, but is not worse either. And, he's actually in the hospital at the moment, but he's being discharged either today or tomorrow. It took him, instead of, we send them home the next day, it took him 5 days to get better. So that is the point. And what are the ethical issues that we are thinking of here? One is beneficence. Second,
patient autonomy.
Patient autonomy. Very good. And third, we must also describe the non-malfeasance. What is the risk of surgery? We may be giving him some trouble. Surgery is injury, controlled injury nevertheless. So the principles that we are looking at here are beneficence, non-malfeasance, and patient autonomy. Okay, that's case 3. Any comments, Nitya? You want anything? You want to say anything?
No, sir.
The patient is 80 years, sir.
Yeah.
Hello, sir.
Yeah.
And he has a will to not to touch the patient. And if a patient comes with a severe sepsis, only because of acute cholecystitis, should we do? We know that if the patient,
just hold on for another case. Okay, just hold on. Very good question. Okay, case 5 will give you a similar scenario again, which happened to me, but this is case 4. Post neurosurgery for MCA thrombosis. Okay, not a great recovery from this. Actually happened in Sagar, and in fact, you guys may know it because Munreddy keeps talking about this case, about what decision I made. Okay, so post neurosurgery, MCA thrombosis, abdominal distension, features of sepsis, hypotensive on 3 inotropes, pneumatosis intestinalis, which suggests what, Ines?
So like air in the
what does it suggest?
walls. So like the entire blood supply is compromised.
Next
like
line,
ischemia.
man. It's there on the
Ischemia,
slide.
yes,
Yeah.
Yes, sir.
Okay, it's on the line.
Yes, sir.
That's why I said,
Yes, sir.
Pneumatosis is on the slide. Pneumatosis intestinal essentially in this scenario means bowel ischemia. So the family said, whatever happens, I don't care, even if there's 1% chance, you please operate. Okay, this patient was very ill. He was practically comatose, had no chance that he would recover. And my reading of the situation was that this was a pre-terminal event. And the patient said, you must operate. The patient, I had no chance of talking to the patient. He was not compos mentis. Family said, please operate. And I did not operate. Okay, I told them very clearly, it is something that I cannot work on. So what are the principles that are involved here? Okay.
Beneficence is
I knew that
Non-malfeasance.
beneficence would be violated. I knew that non-malfeasance would be violated. All right. I had no idea about patient autonomy. Justice doesn't figure at all.
but how
So,
beneficence is violated, sir? It is you're doing it in patient's best interest.
but I know
Best
as a
interest is 1%
professional,
chance.
yeah, that's not chance for me. I want at least 60-70% success rates.
Yes, sir. So you are acting in terms of patient's best interest
By
only, no,
not
sir?
operating, because
Yeah,
the
so you
no,
are in the
no,
line
if,
of
correct. But what I
beneficence.
meant was, if I operate, I'll be beating beneficence.
Yes, sir. If you operate,
If I
yeah.
operate, I'll be beating beneficence, and
Yes,
I will
sir.
be beating non-malfeasance also, because I
Yes,
will be
sir,
harming
yes.
the patient.
The patient, correct.
Yeah.
Yes.
And that is why I did not operate. Something else happened, that's a different matter. But I wanted you to think about the situation which you will be facing on ethical terms. That was the idea of bringing this case. And this is what Vinod raised. It's another very interesting case I had, okay? Obstructing sigmoid carcinoma, severe vomiting and distension. He had localized guarding suggestive of actually a localized perforation. It was not generalized, but it was very, very tender in the left iliac fossa. He definitely needed surgical intervention, if not for anything else, the obstruction. And he was a priest, he was a temple priest. And he said that if you cut my abdomen, okay, my soul leaves my body and there is no purpose for this body afterwards. It's his strong belief. He was compos mentis. He was not septic and confused and delirious. He was with it, but very uncomfortable, in a lot of pain. So what are the conflicts here, Vinod? You tell me.
Autonomy is first thing.
Correct.
And beneficence again. If you don't do, again the patient goes bad.
If I don't do the operation, I'm beating beneficence. Yes. And if I do it, I'm beating autonomy.
Autonomy.
All right. And so what do you think you should do? And you may argue further and say, you're failing in your responsibility as a good surgeon in not relieving the patient's discomfort. That's another way of saying beneficence. So what should you do in this situation? What takes precedence? Remember, in all these scenarios, you know that there are conflicts between different pillars of ethics, but we choose one over the other knowingly. And so that's what must give you the understanding as to what takes a higher level of consideration than the other. Okay, here, what would you do, Vinod?
So I will explain again, because beneficence is more important, I feel.
Yes. Okay, and then the patient refuses. And the family tells you, sir, don't tell him that you're taking for surgery. Just take it. Actually happened. Just tell him you're doing a test, take him to the OT, put him under and do the needful. Okay, what would you do?
I think we can do, sir.
That's where the problem is. Okay, I
Sir,
didn't know.
I think we should not do, sir, because it's the patient's own body. We are
Correct.
violating the patient's own.
If he was
Absolutely.
compos mentis, maybe
Correct.
you could have taken that. But
Yeah.
with
Correct.
I would, medically speaking, I would just tend him and leave him alone.
Correct. All right. That's what I would do. But though these were days before stents were very popular, and he's also a person who could not afford these things. If you told him your total bill is going to be 60,000-70,000, he couldn't afford it. But both cases were there. And also remember, the third point against stenting for him, apart from the money and all that, was a possible perforation. I would not have helped him with stenting. Of course, you could argue I would give antibiotics and hopefully he would survive a limited leak. But whatever it is, I just left him and he went home to die. Yeah, go on, Vinod. You were saying something.
That's what, sir. Again, doing something is something. We know that he'll come out and we are not doing anything.
This is the whole point of this discussion, Vinod. So here, the patient's autonomy is ultimate. That is the ultimate level. So even though you're beating beneficence, patient's autonomy takes precedence. Have no doubt about it, and so you don't do it.
I think there are not many of these Jehovah's Witnesses in India.
Yeah.
But there are a lot of them in England and in the West, and they are absolutely clear. Even with the major trauma, they will never have blood transfusion. So you can't help it. It's exactly the same situation.
I was going to say this. We had a patient in Aberdeen, Jehovah's Witness, young girl of 60 with a hemoglobin of 2.8, as I remember, with Crohn's and bleeding. And they said no blood transfusion. So we actually operated on the patient, put her on hyperbaric oxygen. Aberdeen was the oil capital of the UK. And we had all these people who would be in, because of bends, about the depth and, deep sea divers would not surface quickly. They would go into these hyperbaric oxygen modules, into those things. So we had discussed it with the family, with everybody, and I can tell you she survived, to tell the tale. And we gave her total dose infusion of iron after the bowel resection, and she survived. Okay, that's a very, very interesting thing. But yes, Ravi is right to point out, if we don't have too many Jehovah's Witnesses, I had only one patient here, and with not, with 6 or 7 grams, I operated on the patient long ago. And that was not a big challenge, not a challenge like the one we had in Aberdeen. Okay, so the conflicts are here, autonomy versus beneficence, and autonomy wins. Okay, so
the patient has come.
Sorry, go on.
If the patient has come conscious only, but after coming, you advise surgery, he said no.
Yeah.
And patient has deteriorated conscious wise.
Yeah.
But
very good question. I really don't know what I would do, because I knew that he has told me that not to operate, and then he becomes comatose. What would I do?
Advanced directive will work, I think, sir.
Yeah. It is an advanced directive, right? It's not written down, but he has clearly told you that I don't want it. So I wouldn't do it. So we
Sir,
go on.
From the discussion, can I tell the line that ethics are patient-centered or ethics are surgeon-centered?
Always patient-centered. No two ways about it.
Okay.
Always patient-centered. I'm very glad you raised this very specific question. And if all of you learn that it is patient-centered, this discussion would have served its purpose. Always patient-centered. Ravi.
I think Nikita, I think sir is already always stressing on patient autonomy. That is number one principle. So when that is the number one guiding principle for you, so it has to be patient-centered.
Yes, sir.
So when you are talking about, case 4 or case 3, I forget now, we talk about futile surgery, and we need to learn a little bit more about futile surgery. Because of lack of time, I think I'll just go through the things rather than, have a big discussion. But I would like you guys to remember that it's not just surgery. There is futile medical treatment also. Okay, futile treatment is a general term, not just surgery. Around you in this country, you see a lot of futile treatment, and it really, hurts me to see that, but I don't say anything about it because it's between the consultant and the family. But I do believe that when I counsel the family, large majority will agree with it. And many times after futile treatment is given, people have come back and told me so much time and money was wasted. I don't know why nobody advised us about this. Okay. But I do agree that there's a small percentage of families like the one I encountered in that case with MCA, thrombosis and surgery, who will say, no, I don't care about time and money. You do it, whatever the things are. But you and I must learn about futile surgery. And it is controversial. There is no final word said, and there's always a discussion. And as I said, it's always debatable, and it always has ethically strained issues. You have to understand that nobody can say this is futile surgery, this is not futile surgery, for sure. And so one has to use one's pragmatic, logical approach. We mentioned about effect and benefit. Correcting a physiological or a biochemical abnormality is not the issue. How is it benefiting the patient? It doesn't matter if the patient is still bedbound after the potassium is corrected. All right, that's useless. Cost versus benefit, extremely important in our country, because many patients will run out, even if they have insurance, they'll run out of the insurance and then they sell properties. That I have seen patients who have sold their only lands, which are their only means of subsistence to the family, and then take home a dead body. So please understand, It's all very good doing a huge, 1 month intensive care, but it wipes out the family's finances. Remember that has to be explained to the family and consent taken. Harm versus good. Every single thing that we do has an element of harm. Okay, so please understand that there's always a balance that you have to strike. This is subjective. I'm not saying you can have laboratory parameters and scoring systems. There are people have, devised a lot of scoring systems, but still, medicine and surgery is not a precise science. It's not mathematics. So we must understand that so how do you get over it? The only way, as we discussed a little bit earlier, we're going to discuss again, is to have a discussion, frank, open discussion with the family. Patient autonomy versus doctor responsibility. We have already answered that, we know. Autonomy definitely takes precedence. Quality and quantity of life. And I'm very, very clear. I've written a will in my own, in my own case to say that I don't want to be on an ICU. I've lived my life, I've enjoyed my life. I need to have a good death. A lot of people say this very clearly, and they articulate it particularly in the West, and they say, I've lived a very good life. I want a good death. So you really don't want to be stuck on a ventilator for weeks and months, with doing nothing. If you have led a useful life, that's what you should have. But the line above that is important. If somebody has written and given an advance directive to say that whatever happens, I want to live. And there are some people who are, I'm not sitting in judgment on them, but there are people who have asked for their bodies to be preserved in liquid nitrogen, thinking that at some stage in the future, there may be a technology which will revive them. Okay, it's actually happened, and there are several bodies, particularly in California, being preserved in liquid nitrogen. So please understand that these are very nuanced, and they are very controversial and debatable, but you have to listen to the patient. But when we talk about futile surgery, the important things that we need to have is to understand about goals of care. Okay, so what are the goals of care, both for the doctor and the patient? We talked about a quality of life, which again is a little debatable, but regain function. If you do some surgery and do something, patient lives but cannot get out of bed. Some people may say, I don't want to live such a life. I want to be active. I want to go out. Obviously, there is no controversy in the goals of surgery. There is no controversy in this last item, which is palliation of symptoms. If you have a perforated obstructing cancer, okay, you may just do a resection of that perforated obstructing segment, give them a colostomy. They may not like a colostomy, I understand that, but that can at least be managed. But he may have several months or even years of useful, they can live, they can walk, they can do their normal activities of life, and that can be explained. And so in terms of palliation of symptoms, a fracture in a patient in a metastatic disease, it's a pathological fracture. There is no controversy. It's not futile surgery. You are palliating by fixing it. You're doing a joint replacement or putting a plate or an intramedullary nail or whatever. No So palliation is something that we must always, stress on and recommend to the patient. But if the patient says, I don't want even that, give me morphine, you have to accept it. There are two terms which are not to be confused with futile surgery. This is something that you have to know. Okay, hopelessness. It is a negative emotion of the patient. Any professional doctor will not feel hopeless, because I know that when I'm recommending excision of an obstructing cancer of the bowel or whatever, I know that it's good, but the patient may not look at it like that. It is hopelessness. So you must tell him, try to counsel him that, don't have a very nihilistic or a negative attitude. It will help you. That's one. Health rationing is something which doctors do. Hopelessness in doctors is extremely rare, but there are some patients or some doctors who may even, wrongly say, no, his age, don't do it. That shouldn't happen. But most of the time, I think hopelessness comes from the patient's side rather than the doctor's side. But health rationing comes from the doctor's side. And that is something which has to be avoided. in our country, it's not a big problem because you tell them about the costs, particularly in private practice. Either they have the money to do it or they don't have to do it. So from your end, there is no ethical conflict, but the conflict comes in a government system. NHS, it used to happen all the time. You have limited ICU beds. You have an 80-year-old who has had a bowel resection and was leaked, who needs intensive care. There's a 50-year-old next to him who has also had a similar problem and has leaked or has some other problem, a pneumonia, where you know that he's going to be a lot more productive citizen than this 80-year-old. Okay, what do you do? That's when health rationing was actually occurring all the time. And it happens all the time, even in the developed countries. I'm not saying it's right or wrong. I think that's something that society has to decide. But all I'm saying is that health rationing is not considered under futile surgery. Quality of life is something which is difficult to define. Really, it is very, very individualistic for each one. Somebody who's just being alive may be enough. For another person, he may just being in bed, able to live a pain-free life, even if he needs nursing, may be enough. But there may be a guy like me who says, I want to have an active life, reading, understanding, going and helping others. Without it, I don't want my life, So these are all difficult to define. As I said, individual choices have to be respected. Autonomy is a very, very important point. We have said this many, many times. It clashes with surgeon's conscience. It really clashes with you. You are convinced that you can help the patient, but the patient says no. We know, again, as you said, it is a very valid question that you raised. That's why I have spent so much time and put information on the slides to impress upon all of you that a patient autonomy rides over a surgeon's conscience. And what most people agree, particularly in the West, I don't know, we haven't had big discussion in our society here, continued biologic life without conscious autonomy, which is basically a vegetative life. Okay. And I believe I've seen several court cases in this country where families have gone for discontinuation of treatment, and courts have favored discontinuation of treatment. So I think largely, even though there is no public debate about it, we agree that a vegetative state is something that nobody wishes. About that, there is not much debate. Everything else above that, somebody is conscious, he may or may not understand, but he's conscious. You know that he's feeling pain. He may not be, he may be aphasic, he may be paralyzed. What should happen to him? It's just above one level above a vegetative state. What do you do? Okay, so that is something again which goes with autonomy. And many times in our country, the decision is made by the economic status. Somebody who is very well-to-do may manage it, but many may not. Conflict resolution is something that we have to understand. And I'll go through this, and this is where, after I say this, I would like all of you to comment on this. When you have an ethical conflict, okay, please understand that you should not be alone in making decisions. If you, in that case where I refused to operate, we actually had a recorded counseling session. When I refused to operate, the neurosurgeon was there, family members were there, and we said you could, we clearly said that you could ask some other surgeon to operate. And if they want to do it, I have no objection to it. I really have no objection to it. So you must have some kind of a group discussion, involve your consultants, you must involve the family, other doctors, your colleagues, and administrators. All of them must be there, and preferably it is in a counseling room with no disturbance, with cell phones and things like that, and preferably it is recorded. And you must follow a defined process. We don't have this defined process, but I have informally I have followed this because I knew about this for a long time. You must check for an advance directive first. If the patient is mentally sound, none of these things occur, because in the presence of everybody, he says, I want it done, I don't want it done, no problem. So in a situation where the patient cannot communicate, so the first thing you do is look for an advance directive. Involve the family from the beginning. That should not be the day of resolution. You should, when you know that you're getting into a potentially problematic thing, all the important members of the family must be kept informed. And when you are looking at all the options, okay, you allow an intra-institutional transfer. That's exactly what I did that day. I said, look, I'm not going to operate, but some other surgeon here can operate. You can ask anybody you want. In fact, the neurosurgical colleague of mine had already spoken to other surgeons, and other surgeons had agreed to operate. I had absolutely no comment, or I never even thought of a judgment about it. It is an individual judgment of the surgeon concern, and I respect that decision. If no surgeon in your institution is ready to operate, they all go with you. You must transfer the patient out of the institution, where that's when the administrators come in, and always tell them, look, we may not be able to do much good, but we will make sure that your patient will not suffer. That kind of reassurance must always come. This was very extensively discussed, and it was devised in a hospital in Houston. So it's called the conflict resolution process in Houston. Nikita, your hand is up.
Sir, in case if someone else is operating, after we clearly counsel that they are not going to operate because of the risk-based fit, whatever.
Yes.
And the patient actually survives and just stays. No, there is no good quality of life, but still stays well.
Yes.
Are we legally obliged for anything else? Because we were in the first place, we told it won't be beneficial, and we said we won't operate. But
correct.
Someone else operated, and patient is doing good.
Yeah.
So
what is doing good? That's the question. So, it's very, very rare that the patient will survive. Very rare. You're looking at a 0.001%. But if the patient is alive, is he having a good quality of life? Is he awake? Is he walking? Is he eating by himself? Is he conscious? None of those things is going to happen, because his underlying problem of MCA thrombosis and a vegetative state was not what you wanted. So you have no problem with it, because you can then tell the family that this was my definition of beneficence for the patient. I wanted the patient to be an active, useful member who is not suffering and who is conscious, oriented, and leading a non-vegetative life. And that will not be met. And that is why there is no problem. And in a very, 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 very rare instance, if that happens, you have to eat your humble pie and say, my decision was wrong. And it's very rare that happens. Ravi.
Yes, sir.
Yes, sir. I think, conflict resolution is I think a very sensitive issue, should be handled with great amount of precision and care. And in every stage, the patient's relatives should feel that the surgeon is on their side and they are looking at the best interest of the patient, and there are no other factors that are affecting
considerations. Absolutely. Very, very correct. And Nikita, you raised a very important question. Please understand that whatever your experience is, you may be a junior doctor, you may be a young consultant, an experienced consultant, whatever happens, one cannot think that his judgment is always 100% correct. That humility must be there in all of us. I, for one, in fact, I openly tell my patients, I don't claim that I know everything about surgery. I really don't. Nobody knows. And it is very, very important to, when you have that frame of mind, you can have an error in judgment. And society, particularly the law, allows you error in judgment. Negligence is not allowed. Please read up about negligence, difference between negligence and error in judgment. An error is judgment is allowed in the law. Society allows you that. Not that you can keep on making errors in your judgment, but what the law means is in these situations. So when you really document all this, record your conversation, put it in writing in the case sheet, I had done all this, then it's unlikely that you will ever lose in a court of law. I can always say that, look, this is my judgment. I even when I said you can go out of this institute to some other hospital, or you can get treated by some other consultant in the hospital. That's perfectly legally and morally correct. All right. That is the important thing that you must understand. And
Yes,
so,
sir.
and then, of course, the American Medical Association talks about 3 phases. Okay. The first phase is discussion and negotiation. All that we have said now is discussion and negotiation. We have also mentioned about offering alternatives, which is change the physician, change the institution. But it also goes one step further to define closure. I think it's important for closure for both the hospital and the patient and the family and the institution. Okay, you can't leave it in a limbo. So even though it is not specifically mentioned in the Houston process, in the AMA process it is mentioned, but they also clearly say that after doing all this, they may have legal ramifications, but you are at that point in time prepared to face it. Okay, you may think you've done everything you can, but you may find a patient who says, I was unhappy with the way this guy spoke to me. I'm unhappy with the way that happens post facto. Many times this happens, they'll be very nice to you when you're talking to them. They agree with you, nod their heads, and then, when the patient dies, they go home and sue you. That has also happened to me. But doesn't matter because you have done what you can. You don't have to collapse when there is a legal, a case hoisted against you, because you have followed these processes. It is very, very unlikely that the courts will go against you. And if the court goes against you, it doesn't matter. You can go to a higher court. If the highest court goes against you, then you just can't do anything about it. And you have you have your medical insurance. But I'm looking at a very, very extreme case. I think these things do not normally happen. It may happen in maybe 0.5% of your cases. That's all there is to it. Okay. So I end here and say that this is very, very relevant. Robin Williams, he's an actor. But I like this quote from him that our job is improving the quality of life, not just delaying death. He says that of society in general. All right. Thank you very much. And I would like comments, and it's 8:44. We have another 10 minutes. Comments and remarks, starting with the babies of the group. All right. Ainas, Samir.
So it was a very good class. We have not ever thought of these topics. So how to deal with these situations, it's very important to know all of these, sir.
Samir?
Yes, sir.
Hello.
Yeah,
Yes, sir. Very different class, sir. I never thought about those things and reflect on.
All right. Next in hierarchy, Praveen.
It's thought-provoking, sir. Actually, we will be thinking
So what
in
will
this
you do
angle
after
for
this?
many cases.
What will you do after this?
We will follow the pillars of ethics, sir, from now on.
Not only that, I want you to read about it, okay? This
Yes.
should stimulate you to read on the subject, okay? It doesn't have to be that it's asked. It is actually asked in your exams also, but I want you to go one step behind. So, Nikita, what would you read in all these topics that I have discussed? What would you
Sir, I
read?
would actually like to read few more cases, case studies. Because
Excellent.
the pillars are always there, but the question comes which pillar versus which pillar and what to choose.
Very true. Very true. Good.
Yes, sir.
Yeah, there is
And
plenty
I just have
available.
one more doubt, sir.
Yeah.
In a practical situation currently, if the patient is insured, like there is insurance, and if you are opting out of treatment, there is the conflict again, sir. So
what
would
is the
that come under
conflict?
these any of pillars?
No, what
Sir,
is the
if you are
conflict?
not, if you are going for a palliative care, or if you are like telling that patient won't make it much,
Yeah.
so they can't go Dharma because insurance won't be claimed. At the same time, they can't keep on putting in the hospital and claiming the insurance because they also want interim analysis and everything, sir.
No, that won't be a major issue. I don't think they can. You can discharge them on request, and the insurance will still be paid. Yeah, it's not
Okay,
Dharma.
sir.
It's not Dharma, but you can discharge them on request after proper documentation, and that won't be a conflict.
And so
Okay,
in such conditions, like hospitals should also have the provision, right, to sort of, if at all there is a conflict in the insurance purpose, then because we are not giving them the provision.
No,
And
some
if they
some hospitals don't have the provision, in which case you are within your legal rights to shift them out of the hospital. All right. So I'm glad to say that SHRC has that provision. They write off the bill sometimes, they reduce the bill, and we also have access to some trust funds from which we pay the bill. So it is
moral ground.
Non-moral ground. So SHRC is a trust hospital. It's not a private hospital in that sense. You know, it's a not-for-profit hospital. I don't know if you knew this, but it is a not-for-profit hospital. So I think I'm very lucky to be able to work there. Yeah. Yeah. All right. Vinod.
Sir, actually, before this class, I am thinking it's a so boring topic. But once the class has started, it has given a good high, sir. Definitely, I'll read about it.
Please, all of you, read about these topics. It's very important in your life as a surgeon, not just learning, as I keep telling you, pancreatitis, gallstone disease, and colon cancer. There's much more to surgery than that. All right, Nikita.
Yes, sir.
We lost you.
Hello, sir.
Yeah,
Yes,
yeah,
sir.
we can hear you now.
This is the most important topic, sir, which is not there in the books. Even if it is there in the books, we don't understand it. I thought you would actually take a good class on it, but you took 2 good classes on it, sir.
Oh dear, thank you. Okay.
2 classes. Yes,
Great.
sir.
We can have a lot of discussions in future also. I have a lot of case scenarios, which, you know, over 35, 40 years, I've faced all this. I'm sure Ravi will come up with his own cases. I'm sure Ravi can take a very nice class on this as well. Because these things, we have lived through this in our training, you know. In the UK, there was a lot of unsaid, just practical experience. We have seen our consultants behave the way they did. Remember, it's national health, so money was not an issue, but still there was health rationing in a way, there was decision making. And so I'm sure Ravi will also have a very good class on this. Yeah. Nitya.
Sir, very useful practically. Like I think this anecdotal references that you give, that impacts a lot, sir. That will help us guide through how we have to do. And we're looking forward to something like a case files or similar anecdotes in future, sir.
We'll do lots of it. Yeah. Okay. Sanya.
So very, very nice class, sir. Actually, these are the things we are more scared of, I feel, sir.
Yeah.
Because other complications are known to us, sometimes happen, sometimes don't happen. But when complications happen, or when we are taking up, should we take a person to surgery, knowing when not to operate, all that. I think these are the principles that play a very important role in that picture, sir. So we have to know these and eventually, especially us when we are about to start our private practice.
What I would recommend is that when you have a case in the hospital, all of you youngsters, you don't even need all of us around in a formal class like this or a cup of coffee. You discuss apart from the surgical aspects, the ethical aspects. Make it a habit, and all of you will learn. And if there is a conflict amongst you, you can't have a you can't have a resolution. Talk to Ravi or me or anybody else, any seniors, and learn from that. Closing remarks from Ravi.
Yeah, I think, sir, if with your permission, I'll just give them couple of scenarios quickly to see whether they can answer that.
Yeah, 5 minutes because I have a meeting at 9. Yeah.
Yeah, young man who came with severe left iliac fossa pain, and ultrasound said there is a hernia, and clinically there was no hernia, but he had left iliac fossa pain. The ultrasound report was very clear. So I told him very clearly, I don't feel the hernia, but I will do a diagnostic laparoscopy and see what is the situation. If there is any other cause for the pain, clinically, definitely no hernia. I believe hernia is a clinical diagnosis. And we actually did a diagnostic laparoscopy, and no surprise, there was no hernia. And we did a proper diagnostic laparoscopy, and we didn't do the hernia repair. We came out. So this is standard. So far, there is nothing wrong. Now the problem is because we didn't do anything. The insurance company refused to pay. So Sanya, what will you do now? The patient is blaming you, sir. You should have done something, or you should have written something. But you are very true to the thing and said no. The diagnostic laparoscopy was normal. Now they are refusing to pay, and he has to pay nearly 1 lakh rupees or whatever that hospital bill was. So what will you do?
So first of all, we have explained the patient in advance that if there is no hernia, we will not be doing anything.
Correct. Yeah.
Which he was aware of.
Yes.
And if he is financially not that great, maybe talk to the hospital and lower his bills.
Okay, that is one. So legally and ethically, do you agree with what I did?
Yes, sir, definitely. Unnecessarily doing a procedure just for the sake of insurance, I don't think so is right, sir.
So I think I had counseled him properly and I did the right thing. So I went, what sir said, I went one step ahead. I took the number of the insurance company, called them up and told them this is the situation. It was explained to them also, but you should understand that we have done the right thing and we have reduced your cost by not doing the operation. And it was done because he had pain. Now his pain is resolved. So there is something good that has happened. I wrote a letter to that, and fortunately, the insurance company agreed and paid the money. So maybe that was, probably lucky, but it happened. So as sir said, sometimes you have to, the legality we are fine. Sir said legal aspects is one, and the ethics goes one or two levels above. So by doing that, fortunately, I think we were ethical also.
There's one, just on this case, I want to quiz them further. Sanya, it's good that one sensible insurance officer, actually gave the money. Suppose he hadn't done it, is there any other choice that the surgeon has?
So can we not just write one procedure name alone, not doing it?
Never do that. Okay. That takes away your integrity, number one. And number two, you were legally and morally correct until now. By writing something, you have
There'll be a
become
documental
you have manipulated the document. Okay.
Yes,
Yeah, that is something never done. But there is another option that I want you to be aware of. That's all.
Our fee can be
No. There's another option where
claim it, sir. Like legally, we can sue
what do
the
you do? What is that called?
insurance company kind.
No. Yeah, you can go to court, but before that, there's another simpler thing called the ombudsman. Whenever there is a conflict of non-payment of insurance, in any insurance, health or motor insurance or whatever else, accident insurance, you can go to an ombudsman, and they generally are a lot more sensitive. Next case,
what is that, sir?
Ombudsman, OMBUDSMAN. This is a neutral, wise man who will decide on things short of a legal procedure. Legally you have to pay the lawyer and wait years together. Ombudsman works faster and it's not expensive. Yeah. Ravi, last case.
Quickly. See, there is a patient who has carcinoma stomach with liver metastasis in the porta hepatis, and lung mets also, lung nodes and lungs, and some ascites also. The patient's son was being counseled by the oncosurgeon, who said, your father has at least a 2 or 3 or even 5% chance of doing well. If you can't absolve yourself of responsibility if you don't agree for surgery. Now the son is sitting there with the father. The father will think that son is not prepared to spend his money for his sake if he refuses surgery, but he knows in his heart that surgery is futile. So what now the conflict of interest is for the son. So what should he do? Anybody? Nitya?
I think he should go ahead and get the surgery done, sir. That will give him that.
Nitya, you have not understood anything in this class. If you two things you have actually completely this one. What should he do? Sanya or Vinod for that matter, or anybody?
Sir, we should not do the surgery, sir, definitely. But I think we have to, from our side, we have to explain to the.
No, but now you are now talking as a son of this father. You are not the surgeon who is dealing with the surgeon. Unfortunately, has done the thing. So now, how will you resolve the issue?
We should take a go to the patient and we have to explain the things.
So that is actually your the surgeon is, even though he may be wrong, you are actually undermining him. So as the Tanya, you want to take that?
I think we'll have to close, Ravi.
Not
We have
sure,
only
sir.
3 minutes before the next meeting here. Yeah.
So Sanya,
just give the answer, please.
Yeah, what I would do is, as a son, I would, respect the surgeon's opinion. I'll say, I'll come back to you and go and meet another surgeon and explain to them and see this is the situation and what would you say. Maybe not take the father along, and then once you know the opinion of that surgeon, who most hopefully would not give the same answer as the other surgeon, then you take his father to him and say, surgery is futile. We will, make sure that you are treated, but no surgery. That is probably my take on that.
I would agree. Take a second opinion, in short. That's the one. Okay. Guys, thank you very much. I think it's been a good discussion, and yeah, we will have similar things from time to time. But please, my final comment, please read up about these things. These are very, very important for you to blossom as surgeons. Good night.
Good night, sir. Thank you.
Good night.
Thank you.
Good night.